Good morning, good afternoon to everyone. I hope you can all hear me. I'd like to welcome you all to this seminar. I am Ogochukwu. I lead health financing and governance in the WHO Regional Office for Africa, and it's my pleasure to moderate the seminar today. And so again, I'd like to welcome you to the seminar of the Working for Health 2030 for the 2025-26 series, Follow the Money, Financing Sustainable Health Workforce Strategies, hosted by NHS England and the World Health Organization. This is the fourth seminar in the series, and our aim today is to highlight the importance and need for systematic health workforce strengthening. It is also aligned with the second Africa Health Workforce Investment Forum, which will be taking place in Ghana in a couple of weeks at the beginning of May. As with the previous seminars, we will have approximately an hour of presentations and an hour of Q&A. And as per usual, this seminar draws together global subject matter experts from policy and practice to discuss on how countries can move from aspirational human resources for health strategies to financially credible, politically viable workforce strategies that can be funded, implemented, and sustained over time. Each of our speakers will try to stimulate discussion by posing one question at the end of their presentation. This question should make us reflect on a specific topic and start a debate amongst all of you. Please use the chat section of Zoom to share your views on the question. And please ensure that you send your answers to everyone and not to the hosts and panelists only. Also, feel free to ask your own questions to the speakers. We will do our best to address as many of these in the Q&A session later. And address all your questions to the speakers in the Q&A field in Zoom. This session will be recorded, and the recording will be made available to everyone who's participated over the next few weeks. And so to start us off, we know that across many countries in the world, both within the African region and across all income levels, health systems are facing a health workforce crisis and shortage, which is driving a lot of efforts to increase investment in the workforce. But thinking about the right investments in the tight fiscal environment in which we all operate now is, with many competing priorities, remains something that countries are grappling with. And as you will see, we will be hearing from countries across different income levels and with people with diverse perspectives to reflect on this. But within Africa particularly, some of these has manifested as perhaps an increased investment in production of health workers, but without a corresponding increase in job creation. And this has meant that there is increased unemployment, which seems a bit counterintuitive in an era of a health workforce shortage. But it points to the need for better coordination across different stakeholders, across sectors, both within health, within education and finance, to ensure that as we plan for the workforce needs in the health system, that this is considering the pipeline of workforce production, as well as the financing available to pay for them. And it also means that it is important for countries to think about how to identify and address the inefficiencies that continue to hamper health workforce management, including simple things like the inability to meet, public service rules and recruit health workers within a timeline given, which means we're losing funding that has been allocated to pay them. And so I don't want to preempt what we'll be hearing from our esteemed panelists, and I'll just jump in to introduce our panelists before we start to hear from them. And I'd like to introduce firstly our first speaker, Alex de Jonquieres, Director of Health System Strengthening at Gavi, the Vaccine Alliance. Our second speaker is Dr. Fred Mensah-Acheampong, the Director of Human Resources for Health, the Ministry of Health of Ghana. He will unfortunately not be able to stay through to the Q&A session. Then our third presentation will be a joint presentation from two speakers, James Smith, the Senior Lead for Financial Strategy of NHS England, and Paul Healy, the Deputy Director of Productivity, also from NHS England. And our last speaker will be Dr. Elizabeth Igaga, Senior Director of Program Safety of Smile Train. And without further ado, I'll hand over to our first speaker, Alex de Jonquieres. Alex, the floor is yours.
Thank you, Ogo, and it's a pleasure to be with you all today from Rwanda, where I am in the process of kicking off our new strategy with representatives of many countries from across Africa and across the world. I am the Director of Health Systems at Gavi, the Vaccine Alliance, and I recognize some people may have heard of Gavi, but some of you may not. So let me start by actually talking about Gavi and then come to how we engage with efforts to strengthen the health workforce. So Gavi is a global alliance of partners, which includes among our core partners the World Health Organization, UNICEF, the Gates Foundation, the World Bank, as well as many other civil society partners and other partners around the world. And our mission is to essentially ensure that every child is vaccinated. And in particular, to support the poorest countries in the world, ensure equitable access to vaccination. Since 2000, Gavi has helped countries to immunize over 1.2 billion children. So if we put that into context, that's about 1 in 7 of the people alive on the planet today, or essentially the entire population of sub-Saharan Africa, where I am today. We've supported over 700 new vaccine introductions and campaigns, and so trying to bridge the equity gap by ensuring that the poorest countries can introduce the same vaccines as the wealthiest countries, and that those vaccines reach every child within those countries. And today, children in countries that we support, the lowest income countries in the world, are more likely to receive vaccines to protect against, for example, pneumonia and diarrhea than children in the rest of the world. So we've seen huge progress on that equity agenda. And we also fund vaccine stockpiles that enable countries to respond to outbreaks of vaccine-preventable diseases, including Ebola, meningitis, yellow fever, and cholera, as well as supporting measles outbreak response. So that's our mission, and we've made huge progress with the countries we work with. But while we play a critical role as an alliance in making this happen, it's not us, and it's not even the governments we work with who vaccinate each of these children. It's health workers. So if I could just put up the slide, I only have one slide for today, which is really a slide that just shows some of the health workers who deliver these vaccines across the countries we work with, and what they have to deal with and the conditions in which they work day to day. When health workers are working in immunization programs, certainly in the countries that we support, they aren't just administering vaccines. I mean, that's a critical part of what they do. But they're doing everything. They're responsible for microplanning, figuring out who are the kids to be reached and how they're going to be reached. They often have to collect vaccines from the nearest district cold chain store. They often have to maintain the fridges sitting in their health facilities. They have to travel, often are conducting outreach sessions and traveling a long way to the communities they serve. If they're lucky, by motorbike, sometimes by bicycle, sometimes on foot. But often over long distances on poorly maintained roads. They obviously could provide the vaccines and administer the vaccines, but they also engage with the communities. They are the voice and the face of the vaccination program to the communities they serve. They need to address concerns of that they may get from families, hesitancy, increasingly misinformation about vaccines. They also need to be the record keepers They fill in the registers, they fill in the child health cards, they often have to put information into a data system and report it upwards, and they have to dispose of the immunization waste at the end of it. And they do all these things often in very challenging conditions, dealing with power outages, inadequate staffing, lack of security in many areas, community skepticism or sometimes hostility even, and typically very limited operational costs to support all of this. So they are the true heroes of vaccination, and some of those heroes are on the screen today. So we can take that slide down. I think, as Ogochukwu said right at the beginning, we all know that the health workforce is under strain, and it's under strain around the world. This is seminars co-hosted by the NHS. I am British. I know, although I don't live in the UK, I know from my own friends and family that in the UK the health system is under strain, but the strain is greatest in the poorest countries that we work with. Africa, which carries about 25% of the global burden of infectious diseases, employs only 4% of the global health workforce. And those health workers are often overstretched, and in particular, they're often not even deployed evenly across countries, meaning some communities are completely missed by the health system. By 2030, WHO estimates that nearly half of the global health workforce shortfall, which is about 11 million workers, will be in sub-Saharan Africa. And the gaps are expected to be greatest among nurses, midwives, vaccinators, and community health workers, who are exactly the cadres of health workers who are most critical to immunization programs. There are efforts underway to overcome these gaps, and they're commendable. And for example, Africa CDC is leading efforts with countries in Africa to deploy at least 2 million community health workers across the continent. But there's a long way to go. We know today there's about 1 million community health workers in Africa, so a lot more to do to reach that target. And many of the programs to help countries move forward remain underfinanced, fragmented across partners, and often dependent on relatively short-term donor support. Addressing these gaps in the health workforce is absolutely fundamental to our mission to reach every child with vaccines. And so, and in particular, to reach those what we call zero-dose children, who are the children who are completely missed by immunization programs and don't receive any vaccines and often live in communities that are unserved by the health systems. Every year, we as Gavi invest about $300 to $400 million in supporting countries to strengthen their health systems. And about 20% of that is to strengthen the health workforce. So it's a big part of what we do in supporting countries. In particular, countries use that money to help recruit health workers, to train health workers, to deploy them and to ensure that they have the right supervision and support in their role. But we know that those investments could be a lot more impactful. While $300 to $400 million sounds like a lot of money, it's a relatively small amount in the context of the total needs of countries' health systems, and in particular the needs to ensure that there's a well resourced health workforce. And we see a number of challenges as we work with countries that we undermine the impact of our investments today. Though I'll call out 4 in particular. The first is fragmentation. I already mentioned that there are many vertical programs who are investing in the health workforce, and Gavi is an immunization of one of them. But often those investments are planned in silos, separately, and are either duplicative or leave significant gaps in terms of unmet need. The funding is often short-term and project-based, and not really tied to an agenda of long-term reform of the health workforce and long-term strengthening of the health workforce, with sustainability built in from the outset, which means that when that funding ends, often the health workers who were funded through it are no longer paid. We also see a lot of our funding being used for very per diem heavy activities, so in-person training, campaigns, where a lot of the money is going to paying for a one-off activity. And that one-off activity typically is actually happening outside the health facility. So when I'm feeling a little bit cynical, I almost feel like we're paying health workers not to be in their facility and not offering services. And we also know many health workers today are inadequately integrated into the formal health workforce, and therefore inadequately recognized, compensated and supported. And that's particularly true for community health workers. So we're trying to make a shift under our new health system strategy, which was approved by our board last year. And we really want to work differently with countries, but we need everyone's help to do that. We will remain focused, and it will remain a priority for us to help countries to address critical gaps in their health workforce that prevent children from being immunized. But we really want to shift both what and how we fund. In terms of the what, we want to shift away from short-term immunization-specific investments and really transition towards supporting longer-term transformation of the health workforce, where we are contributing as part of a single national health workforce strategy. And our funding is well aligned to that, coming from other partners, from the government itself. And the sustainability is built in from the start, with a plan for how eventually governments will pick up that funding. And in terms of the how, we want to shift away from a reliance on sort of more traditional approaches like classroom-based training and in-person supervision, and take advantage of new technologies such as digital tools to enable countries to put in place new systems to help health workers learn on a continuous basis, have access to live support and peer-to-peer learning, which we know is one of the most effective ways for them to learn. And so to do this, we need to change how our funding is programmed. We need to break down the silos that exist today, whereby immunization colleagues are planning health workforce investments separate from other parts of the health system, and Gavi funding is being planned separate from funding from other partners like the Global Fund, bilateral donors, the multilateral development banks. So let me come to my question. I'm in Rwanda today with representatives of most of the 55 countries we support to kick off planning of our new strategy, planning of our new funding cycle. Over the next 18 months, those countries will program nearly $2 billion in new funding for their health systems. My question to all of you, if you're from a Gavi-supported country, is how do we work together to ensure that the right actors are in the room as those grants are designed, so that our investments in the health workforce have maximum impact on broader health workforce strengthening efforts in those countries and don't only happen in a silo. And if you're not from a Gavi-supported country, I'd love to hear, what have you learned about how to do this well that we might be able to draw from as we work with countries to program that support? Thank you.
Thank you so much to Alex for that excellent leading presentation. And I will hand over now to Dr. Fred Mensah-Acheampong from the Ministry of Health of Ghana. Fred, the floor is yours.
Thank you very much, Dr. Ogu. And good morning to all my colleagues, panelists. Yeah, for Ghana, as we all know, Ghana is part of the country in the West Africa region of Africa. Our public sector density for health workforce over the years has seen some significant improvement. We have recorded from 16.56 approximately in the early 90s to 41.92 per 10,000 population currently. However, this has still not been able to resolve the issues of our gaps that we have in the sector. The Ministry of Health, as the main force towards achieving the UAC and SDG of Ghana, is the main lead in this force. The Constitution of Ghana is supported by the other commitments that we have with the African Union Agenda 2061 and the other UAC agreements. In the sector, as we fight to improve on the health workforce issues, in 2022, we embark on evidence-based approach by organizing health labor market survey for us to achieve evidence, for us to be able to help us to reform and sustain our investment. The LMA actually gave us some evidence that we as a country are now embarking on for us to be able to turn the tide of the difficulties that we have in the health workforce management. The evidence that we got, the major ones, we realize that in Ghana, we have the capacity of health training, which is about 76,000. But as of now, we are able to fill only 36,000. The biggest of it all is that we currently employ less than 40% of the health workforce that have been trained. And in that sense, it means that we have about 40% unemployment that we are battling with as a country. The funding for government public health sector wages is one of the key problems of our not able to get the numbers that we require. The fiscal space in Ghana is such that you are unable to employ as we need, as and when. And in that sense, it actually creates what we have, the gaps that we have in the health sector, which we are battling to resolve. If you look at our health budget, about 70% is already going to health wage payment, yet you still have difficulties in some of the areas as a result of the gaps that we are supposed to fill. If you look at our projected need of health workforce, as we speak, we are not even able to get to the level of the minimal estimated numbers that we require. We are currently at the lowest level of the minimal level that we require, but the supply that we are having is already up more than the numbers that we have. And this is what is giving us this issue of us not being able to employ. Meanwhile, we also need the staff. If you look at the numbers that you are projected, if you are to go by the minimal will still be under the supply. But even if you go to the one that we think that you'll be able to achieve, you'll still not be able to take up all the stuff that we are currently producing. This actually makes us to have the problem of demand and supply mismatch. Demand is expanding for over 8%. Supply of health workforce is about 14.4%. And this is what is actually creating the problem of accumulated unemployment that we have in the country. So the question is, how do we deal with this problem? As a country last year, we had health workforce dialogue to discuss the ways and means that we'll be able to resolve this issue of mismatch between demand and supply of health workforce. And I want to talk about some of the summary of the things, the recommendations that we all agreed on at that summit. One is for us to automate health workforce education and to train to align with the demand and then the needs of the population. And then two, we are to predict predictability of recruitment pipeline to address domestic needs. And then three, performance and then productivity management. And then four, retention and migration management. These recommendations actually forms part of the recommendation that we also got from the HLMA, which was organized a year before. And as a ministry, these are the recommendations that are we are aligning with our health strategy policy to implement over the years. And this has been consistent from last year up to now. We actually created a theory of change for us to be able to help us to change the tide from where we are to a sustainable financing. One is to align investment in health workforce education with health sector needs, jobs, and manage migration. So here we are looking at our training of health professionals, how we can align them to the current needs that we have as a country. And then if we are able to get access, we can also give those access to other countries that are in need of those specialties. And then to invest in attracting and employing of health professionals, and then to help them to also stay and to sustain health workforce through strategic management and retention. How do we do that? So these have been the innovations that as a country we have been pursuing from last year up to date. So on sustainability, we are looking at how we will institutionalize long-term plans towards sustainable and reliable funding for health workforce. So we are looking at the MTEF planning, a 3-year plan that you will arrive at and then have an agreement with the Ministry of Finance, and that will guide us in employing sustainable employment of health workforce. And with that one, since we will plan ahead of time with the Ministry of Finance, they will be in the position to also offer us some fiscal space that will help us to do this employment. For instance, we developed a comprehensive medium-term recruitment plan, which stays 25% as the highest level and the 15% at the 15,000 as the lowest level of employment per year. But our analysis says that if you are able to do 25,000 employment per year, that will be the most reliable one that the country can have to actually reduce the unemployment rate and others. And the scalability too, we are looking at how to mobilize more resources for training and the recruitment of tension of health professionals. In this sense, we are looking at diversifying the training that we are having now. Currently, most of our training is on the general nursing. We are looking at having some sort of specialties, subspecialties in the area of nursing, as compared to the medical side that have already been developed to have specialties and subspecialties. The nursing cadre is still the general inclined. So since last year, we have been pursuing a process of introducing new programs such as cardiology nursing, endocrinology nursing, oncology nursing, to now specialize more into the area of nursing. And that is actually one of the program that is also in line with the current government initiative of free primary health care, and then also the Ghana Medical Trust Fund initiatives. These are the things that we are doing at the level of HR to support those initiatives. And then the area of equity, Ghana is seriously disaggregated when it comes to the distribution of health professionals. The health professionals are mostly in the urban areas compared to the rural areas. So last year, we came out with a policy of 2080 approach, whereby the recruitment of all health professionals, 80% will go to the deprived areas and the rural areas, and then we will concentrate only 20% in the urban areas and look at where the gaps are in the urban areas, and then we fill in. But the emphasis currently is on the underserved and the rural areas for us to now leverage on to move more people into those areas. And then efficiency and accountability. So we are pursuing measures towards measurable results through performance-based financing. And as we speak, currently we are working on our investment forum and signing of compacts with the Ministry of Finance and other stakeholders so that we can all tie ourselves in on the program that we have over the years for us to be able to finance our health sector. We think that when we do this, if you are able to implement these innovations and you are able to tie in the Ministry of Finance and the other stakeholders for us to employ 25,000 health workers annually over a period of 3 years, you'll be able to reduce unemployment rate that we have in the health sector from 40% to 31%. And then we have also estimated that this one will bring some return of investment to about 10.64, that from a direct investment and from the productivity gains that we also get from the life expectancy of saving more lives of the population. And this will also help us to actually save about 960 mothers per year who would have died while giving birth. Because if you look at the hinterlands, we have few midwives, you have few nurses. So with this approach of 2080 that we are pursuing, we are going to push more people there. So if the Ministry of Finance allow us to be able to get a space to employ more people and then send to these underserved areas, we believe that we're able to save more lives and reduce maternal mortality, as well as to reduce children deaths that we are currently recording in the country. So in summary, we said we will continue as a ministry to promote dialogue with other stakeholders by giving them the evidence that we have gotten from HLMA and the other interventions that we are putting in place now, to be able to persuade the stakeholders for us to get more space for employment of health professionals. And sustainable financing requires credible and viable solutions. So as you said, we have to come out with solutions that are sellable, solutions that the politicians will buy into it, solutions the other stakeholders will also buy into it. And then with the political commitment that we are currently seeing, and with the key encouragement that we are getting from the government, if we are able to implement this, we hope that we are able to achieve our impact that we have set for ourselves. Thank you very much. And I will come back and try and see whether I will be part of the question. I'll go for another meeting, but I will try and come back if I can join the Q&A session. Thank you very much.
Thank you very much to Dr. Mensah-Acheampong for sharing this perspective from Ghana and what you're doing. And thank you to our two panelists so far for keeping to time. I'll now hand over to James Smith and Paul Healy from NHS England. The floor is yours, James.
Thank you very much, Ogochukwu, and it's great to be with you all today, and thank you for the invitation to speak with you. So myself and Paul are based in the national finance team at NHS England, and as part of our contribution to today's conversation, I'm going to talk first about how the health service in England undertakes what we call operational planning, which is an integrated process where the NHS completes financial and workforce planning together as part of a single process. And then Paul's going to talk a bit more about the delivery side in terms of once those plans are in place, how we monitor those and the analysis and benchmarking and how that informs improvement. It's really exciting to be able to contribute to today's conversation because all healthcare systems face the challenge of managing scarce resources and face the rising costs of delivering healthcare each year, as well as the changing needs of the population. And in all healthcare systems, it is the staff that represent both the biggest area of spend, but are also crucial to delivering services and changing lives, as we've seen in the previous two speakers. So making effective investments in our workforce is crucial, and workforce planning is a vital part of being able to do that. And in the UK context, the government has published last year a 10-year health plan for England. And that includes three really important aims: moving more services out from hospitals into communities closer to patients, putting a greater focus on using digital services, and also a greater focus on prevention as well to manage the overall needs of the population. And so that's the kind of context in which operational planning takes place in the NHS. And so then if we move on and just talk a bit more about how the planning process in the NHS works. It's a large scale national process. It involves more than 200 organisations, thousands of managerial staff. It takes several months to complete, and it covers more than £200 billion of public expenditure. So it represents roughly about 7% of the UK GDP. So how does that work in terms of the structure of the NHS? So on the commissioning side, we have regional bodies who are responsible for planning and contracting for services. So these are called integrated care boards, and they're the kind of coloured areas of this map. And they perform the kind of payer role within the English healthcare system. And then on the provider side, we have a mix of public providers, NHS trusts and foundation trusts. And then we also have primary care, and we have independent sector providers as well. So not-for-profit and private providers that provide NHS services. It is the commissioners and the public providers who are required to agree plans with NHS England as public bodies for each financial year, and then they're accountable for delivering those. And so following the 10-year health plan that I talked about, integrated care boards and NHS trusts have completed 3-year plans to the financial year 28-29, which is the first time we've been able to do a multi-year NHS planning process since the COVID-19 pandemic. So if I just go on the next slide into a little bit more detail about how the process works. So in terms of the information we provide nationally, there will typically be a national document which sets out kind of priorities and direction of travel, and that will include a combination of transformation objectives. So what are the kind of service changes we're expecting to be delivered? So that will align to the 10-year health plan, as we talked about. It will also include performance standards, which are often focused on access to services. So how long do people have to wait for emergency services, for elective appointments, etc. And then also there might be particularly important quality or safety measures that are being introduced, which are included in this as well. From a finance perspective, we would be issuing financial allocations for commissioners so they know the amount of resource that they are able to plan with. And then we'd also set out rules in terms of, for example, the payment scheme from the commissioners to the providers and how that operates so that the providers can plan as well. So then thinking about how does that work locally, there's 3 really important dimensions of integrated planning. So firstly, in terms of activity, organizations will need to understand what is the local demand growth in their area. And then they'll need to think about the capacity they want to plan to meet those that demand, and also any service changes they want to implement, including where that might help, for example, to moderate emergency demand elsewhere by introducing more preventative services. And then they'll need to analyze what they think the impact of that will be on their performance against some of the access standards that we talked about. In terms of workforce, they will then need to think about how the level of workforce growth that they need to deliver those services, as well as the professional mix. So where we're talking about, for example, having a more multidisciplinary workforce to deliver service changes, that's where that will kind of come into the plan. And they'll also need to then think about the right balance between substantive and temporary staffing. And then finally, from a finance perspective, clearly the services and the workforce that they're planning for need to be affordable within the resource that they have. They might also need to think about what new technology, what scanners, new buildings, estates, etc. they might need, and how they use capital investment to support that. And then finally, at the end of the process, there'll be a plan review process that triangulates those 3 elements to kind of agree that that plan is both stretching and deliverable. So then just finally thinking about what are the kind of key challenges that we face in the England context, and kind of what are kind of some of the key points of learning that we think would be relevant for this conversation. So if we just go on to the next slide. Great, thank you very much. So key challenges, the ones we think about the most are alignment of plans and assumptions. So we have multiple organizations in each regional area of the country, so making sure that they have between them agreed shared priorities and that they have consistent planning assumptions is really important, and kind of avoiding fragmentation. We also have the challenge of the kind of complexity of how you plan across the 3 different domains I talked through on the previous slide, and how you quantify the impacts of the changes you're wanting to deliver in financial terms and activity terms and workforce terms. and also then the kind of other associated constraints you might come across. So you might have the financial resource to employ more staff, but is there the available levels of qualified healthcare staff that you can recruit in your local area? Do you have the building space for the services that you're planning? Estimating the impact of transformation in your plan is really difficult. Strategic changes can be harder to measure. And then finally, I think there's the challenge around how you balance ambition with deliverability. You want to make sure that you're making the best use of the resource you have, but you also need to make sure that the plan is deliverable. And you need to make sure that it's kind of the pace and the phasing of the plan is achievable as well. So just thinking about some kind of reflections for this conversation, I think is integrated workforce and finance planning is really important to be able to prioritize scarce resources, crystallize some of the real life constraints I just talked about. It acts as a bridge between kind of policy and implementation, operationalizing new services, and turning policies into reality. It can also support organizations to understand their sensitivity to risk, so they can model the impact of, for example, higher levels of demand, higher levels of inflation, what happens if there's a higher level of staff absence, for example. Clearly, planning in any healthcare system is inherently incredibly complex. And whilst what I've talked to is an example of a kind of very nationally coordinated process, it's perhaps more of a feature of a centrally planned healthcare system, actually all of the challenges that expose are universal to all healthcare systems in terms of those coordination challenges. I think it's really important that you therefore have a really clear focus on the purpose of why you're doing the planning exercise and really clearly understand the decisions that you want organizations to be able to make about the future. What information do they need to be able to make investments now that will mean that they're on a more sustainable path into the future. And then also finally thinking about how do you balance certainty and responsiveness. So you might want to have a long-term plan, but equally you might be planning kind of future changes, new services in 1, 2, 3 years time. You need to make sure that you have a planning approach that allows organizations locally to reiterate and respond to those changes. So having an approach that matches that context is really important. The next couple of slides include a case study, which I'm not going to spend too long on now to make sure that we have enough time for the rest of the presentation, but just to highlight that this is an example of where we introduced a scheme in primary care to fund GP practices for the cost directly of employing a more multidisciplinary professional workforce in primary care, where we insulated them from the cost to kind of incentivize recruitment of different roles that include pharmacists, physiotherapists, mental health practitioners, occupational therapists. So there is some evidence has been published about the effectiveness of that and kind of includes some helpful learning, both in terms of the positive impact and also the challenges as well of implementing that in practice. But I won't spend too much time on that. So I will hand over to now to talk a bit more about the other side.
Yeah, I'll just.
Yeah, Jane. Sorry, Paul. As you started, I think between the two of you, you now have just about 3 minutes to wrap up.
Yeah, that's
so we
fine.
Have time for the rest things.
Yeah, that's where I'm coming to wrap up. So that's absolutely fine. So James is talking through in terms of the work that we do to help coordinate an integrated planning process across these NHS organisations. One of the key elements and one of the key outputs that comes from that then are a set of plans that not only help those systems to be able to then kind of know what they kind of then go and need to deliver, but also create a set of a concept of ownership of those plans, which help kind of them making sure they're accountable for those plans. And so there is a kind of process that we have, which is around overseeing the delivery of those plans, which this is kind of showing the work that we do to kind of show where kind of systems and trusts are currently performing against those plans and against the kind of metrics that kind of demonstrate the delivery of those plans. So you can see, and this is all publicly available, the dashboards that we have, which kind of set out, and the top graph here is the performance from a workforce perspective, of looking at the people in the workforce elements, and then the bottom one is shown at a finance perspective, and then there's a kind of like a way in which that is all segmented so that you get an overall balanced kind of view, a scorecard of how trusts are performing. And then to support that work, there's a lot of tools and resources that we provide that help to benchmark performance, to understand kind of where different organizations are in terms of performing against other organizations, other systems. So just go to the next slide. It just shows a tool that we have, which is called the One Health system, which this is looking at a lot of productivity data, where an organization, a hospital, can look exactly where they're currently performing on things like how much activity they're delivering for per kind of clinical staff they have, what their performance is in terms of utilizing their theatres and other elements as well. And they're able to benchmark against different organizations, see where there may be improvements they can make, see where they may be doing well. And there's a whole kind of community of trying to share best practice behind that as well. If you just go to the next slide, it shows an example of that from a kind of example in a workforce where you can see what your turnover rate is in terms of staff turnover in your organization, how that compares to your peers, how that compares to organizations across the whole of the NHS. And that's the kind of dynamic of trying to use data to kind of support trust to continue to improve. And then similar to what James was saying, the case study that he was highlighting in primary care, there's also a case study in here which people look at in the slides, which looks specifically at the work we've been doing to reduce the reliance on particularly agency staff, which is a kind of private company kind of provided staff. And so we've used the integrated planning process to drive down spending in that area and try and divert spending towards either substantive staff or a form of temporary staff that's more internal to the NHS. And so that we've used the planning process to do that. And then on the next slide, you can see how in the last few years, we've definitely brought down agency spend, which came out of the pandemic from about 4.5% of pay trajectory all the way down to effectively eliminating it by the end of this decade as part of a government commitment. And then we leave on the questions, which kind of link into what we've done, which is around what complexities in workforce planning happen where you work, and how would an optimized kind of workforce planning process help to manage those, and then what information and tools can help to plan and deliver your individual workforce strategies.
Thank you very much to James and Paul. And I will hand over quickly now to Dr. Elizabeth Igaga for her presentation. Liz, the floor is yours. You have 10 minutes.
Thank you very much. I'll be talking about a project that we're very proud of. It was born out of the need for safe anesthesia and surgery for everyone in Africa, but particularly for children. If we could go to the next slide. So about 1.7 billion children globally lack access to safe anesthesia and surgery, and most of them live in the low and middle income countries. And it is estimated that by 2050, Africa will be home to 1 billion children, which is about 40% of the world's population for children. It's also predicted that 85% of the children in Africa will need a surgical intervention of any kind during their childhood. And the recently published African Surgical Outcome Study for Pediatrics found the mortality rate for children undergoing surgery in Africa is 100 times higher than that in high-income countries. This is obviously a multifaceted issue, but a severe shortage of highly skilled anesthesia providers, including pediatric anesthesia leaders, is a major contributor to this high perioperative mortality among children in Africa. If you could go to the next slide. My colleague Alex spoke about the global burden of disease and the fact that, sub-Saharan Africa carries about 25 to 30% of the global burden of disease, but only has 3% of the world's health workforce. And unfortunately, anesthesia is required to manage that 30% of disease, but as anesthesia, we only get 1% of global health funding. Next slide, please. And so this map speaks to the global anesthesia workforce. As you can see, it basically shows us the physician anesthesiologist population density per 100,000. The Lancet Commission for Global Surgery recommends that every country should have at least 20 surgical anesthesia and obstetric physicians per 100,000. You can see where the need is. The red and the oranges basically show a very low population density compared to the counterparts that are in blue. And of course, as far as subspecialty training, the question that we've been asked is, if you don't have the anesthesiologist anyway, why then do you want to subspecialize and have pediatric anesthesiologists or obstetric anesthesiologists? If you go to the next slide. So there's a common assumption that when you train a pediatric anesthesiologist, they just become a subspecialist. This is far from the truth, as these fellows and subspecialists become system builders, and they do address multifaceted issues. So they take on roles, obviously, as the referral specialist for the most complex patients. They also act as educators, and they do train the next generation. They are performing a leadership role where they do quality improvement and patient safety initiatives. They do contribute to national guidelines and policy formation as they add context to the discussion. And they go around advocating for children's safe access to anesthesia and surgery. And they also are multiplier of skills, teaching all cadres of anesthesia providers. Next slide, please. So I'd like to introduce you to PATA, which is Pediatric Anesthesia Training for Africa. This was established in 2020. It is a collaboration that was founded in Africa for Africa with one goal, which is improving pediatric anesthesia training on the continent. It is led by African anesthesiologists from 8 countries around the world, many of whom graduated from the University of Nairobi program, which is the founding site. The first project of this collaboration is to expand the number of pediatric anesthesia fellowship training opportunities on the continent in a bid to build permanent training capacity locally. So as you can see, we have African faculty, and they came together and co-developed a curriculum that was academically rigorous, but also took into context the local context and is embedded in local institutions. And the focus is to make sure that there's retention, leadership, and the multiplier effect where every fellow trained goes on to train another and the ripple effect continues. We've got 6 collaborating sites, one in Kenya, which is the founding site, in Uganda, where I'm from, Nigeria, Zambia, Ethiopia, and Ghana. And the model is basically to train physician anesthesiologists to become subspecialty leaders and educators for sustainability. The program is accredited by the World Federation of Societies of Anesthesiologists, and that gives it the international recognition that it deserves. And more importantly, this is not a one-off intervention, rather a permanent system training to ensure sustainability. Next slide, please. And so this slide basically tells you what we have achieved so far. The University of Nairobi program started in 2013, and they were training about 3 fellows per year. PATA, like I said, started in 2020. And over the past 3 years, we have been able to train 32 pediatric anesthesiologists, signifying a 145% increase in pediatric anesthesiologists trained on the continent from 2022. I'm very glad to say that we have a 100% retention rate of all these graduates on the continent, and all but 2 have remained in their home countries. And it is estimated that in the first 5 years of this project, over 1.2 million children will benefit directly from these graduates over the course of their career. And of course, keeping in mind the fact that these graduates are going to train others, and those are also going to directly serve children. Next slide, please. This is just a map showing you fellows by nationality, the 32 fellows that I spoke about. You can see we're very heavy in the Eastern Southern African region and part of West Africa. If we could go to the next slide, please. And I just wanted to showcase the geographical spread. So we do have a training hub, which is at the National Hospital in Abuja. And the fellows that have been trained there, as you can see, have gone back to their hospitals. 6 different fellows have gone back to their hospitals spread across the country to provide leadership and service as pediatric anesthesiologists. If you go to the next slide, please. And then this is just a map of Africa showing us where our graduates have gone. 11 hospitals across Africa have employed a graduate either trained in Nigeria, in Uganda, or from the University of Zambia. And 5 hospitals employ University of Nairobi graduates. 16 hospitals have now been newly equipped with a full surgical team. They have both a pediatric surgeon and a pediatric anesthesiologist since 2020. Next slide, please. And of course, none of this would be possible without funding. Smile Train, which is the organization that I work for, the world's largest cleft charity, and Elma Foundation co-funded the program. They did provide seed funding to get the program established and support the first 3 years. There are a couple of other collaborators who have come in to support, and we're also looking at finding alternative funding for the program as it continues to grow. What we have learned from this is that no one writes a blank check for anesthesia, unfortunately, but people will invest in partners who build collaborations, fund workforce equity, and they will fund systems that last. We've also learned funder language, where we have changed the story to suit the funders that we are speaking to, even if the fellowship remains the same. Next slide, please. I really want to reiterate that there is no safe surgery without safe anesthesia. It costs about $25,000 a year to train one PATA fellow, but that's just one person for 1 year, and you can see the lifetime impact that the $25,000 has. Next slide, please. If you're interested in learning more about the PATA program, you can scan the QR code and it will take you to a page that says everything that you need to know about PATA. But I want in the next slide to talk a little bit about the role of advocacy. Following the WHA resolution 68.15, there's been reactivation of national surgical healthcare policies in varied stages, as you can see on the map. Many countries, particularly the SADC region, are now developing NSOPs, and NSOPs is National Surgical Obstetric and Anesthesia Plans to integrate anesthesia and surgery into the universal health coverage. However, as expected, we're facing challenges due to lack of prioritization during funding. Smile Train is working with a lot of these governments to be able to support the NSOP process. However, of course, the national support and involvement and investment is really, really important. Some of the fellows that I have just showcased have actually gone on to lead some of these efforts, and we're extremely proud of that. And so my question to you on the next slide is, as a health worker, what skills and tools do you need to be able to effectively advocate for meaningful and sustainable financing of health? Thank you.
Thank you very much. Again, Liz, and to all the rest of our panelists. We have now come to the end of the presentations, and we'll be shifting over to the Q&A session. Firstly, we'll spend the first few minutes reflecting on the audience responses to the questions that were posed by our panelists. And if I might ask our panelists, can you all see the responses, or shall I summarize for your reflections? Okay, so I will just, for Alex, you asked the question, how do we maximize the impact, efficiency, and sustainability of investments in the workforce? And we could see some responses coming from this. I don't know if you want to, if you see this, you want to share, reflect a bit on these responses, or would you like me to highlight the top points there?
If you don't mind summarize it, that would be really helpful.
Okay, great. So we are seeing responses from, the need to invest in the workforce, in educating the workforce to make sure they acquire the right competencies, to focus on community care in the pre-service programs, not just the medical side of things, bringing in evidence-based solutions from varied types of countries, not just from those that are well established, but also from the ones that are still upcoming. investing in e-health and digital technologies, I guess, being open to different roles in nursing, such as specialized and technical roles, having regulations and policies that regulate and protect the healthcare workers, and training health workers to work in teams. So rather than just the individualized approaches. And that's the building teams around care delivery was reiterated again, capacity building and ensuring a team-based approach to delivering care rather than just program-based care. And so I'll give you a few minutes to reflect on these.
Thank you so much for all the responses and all the reflections, which were really helpful. And I think there are some things which we can act on within that from the Gavi side, and there are some things which I think we're going to need help with, essentially. So maybe to step back. So the Gavi model, and this is true of several of the big global health funding organizations, is a country-driven model. So ultimately, countries are the ones that decide how to use the funding we provide. I mean, subject to certain guidelines, but it's countries who prioritize the funding. And so I think some of the questions around, or the suggestions around sharing best practice and what works across countries is absolutely critical and something we can really help with. Some of the specifics in terms of how the money should be invested is, though, decided ultimately at country level. And I think one of the questions, maybe it's an invitation to those of you who are from a Gavi-supported country and who are engaged in helping to design, shape, manage the health workforce, would be to ensure that you know what the immunization program is planning to do in terms of their health workforce investments. And I would similarly recommend understanding what the HIV program, the TB program, malaria program, which also get a lot of external support, are going to do, and seeing how you can help to shape that. Because I think for us, what we see a lot is immunization colleagues who, with all the best intent in the world, designing investments in the health workforce that are not always well joined up with the country's broader health workforce priorities or strategies, and with limited coordination with broader with the broader ministries of health and other ministries such as ministries of planning that have an important role in the health workforce. So I think we will take on board the feedback and suggestions in terms of what we can do globally. And similarly, as I say, an invitation to those of you who are working at country level over the next 18 months. $2 billion of Gavi support are going to be programmed. If you're not in conversation with your immunization team, please get in touch with them and see how you can shape the health workforce component of that to make sure it's really strengthening what you're trying to do with the broader health workforce priorities.
Thank you so much, Alex. And while, of course, it's fully appreciated, a lot of these will depend on the governments themselves who are programming Gavi funding. But I think the extent to which as well, this is being reflected in your discussions with the countries coming out of this seminar on these suggestions. It's always a useful thing to reiterate that information to our policymakers. And so moving on now to the question posed by James and Paul, you had asked about the complexities in workforce planning for the audience and how an optimized workforce planning process would effectively manage these and what information and tools are needed. We have a couple of responses. One is that with the current healthcare reorganization in England, this is is an England-focused response, and the changing responsibilities of integrated care boards, there is a concern that workforce planning will be lost in the system. And so is there any indication yet where this planning will sit and how the system will ensure local input and ownership? And the second response, which is fully a comment, is that a key element of workforce planning is the mental health of the workforce. And so given that, at least in the NHS, 30% of staff sickness absences are mental health related, and more impact is felt due to presenteeism, taking account of mental health into planning will be critical. And so I'll open this up to you to reflect on the comment and the question.
Yeah, sure thing. So, I mean, on the very specific kind of England question about kind of reorganization and structures, I think, I mean, we've been for a long time quite a kind of constantly evolving dynamic in terms of the structures of the NHS. I mean, one thing to highlight particularly on James was talking about the purchases, the kind of the areas and the systems, that is constantly evolving. And one of the things that in this planning round that we've done for the multi-years, there was 42 footprints for the regions. That was up until last year. In that one, what's been done for this multiple year, there's 36. There's already arrangements where they're kind of clustering together. So there is this kind of dynamic of where what kind of level of population to look at for planning can sometimes, there are some services where actually looking at it from quite a wide footprint is more valuable. So certainly when we look at things like ambulance care, ambulance services, they tend to look at it from a much bigger footprint than just in individual areas. But even within some of those areas, it's still important to look at where they're actually what we kind of call a dynamic called place, where you want to look at it actually even smaller area. And so there are arrangements within some of those organizations to kind of look in different areas where you might have, for example, an urban population and a rural population within the same area. So I think some of that dynamic does generally change. Obviously, there are people involved in that because there are changes in structures of which we're kind of included in as well. And as I say, with regards to workforce, some of that work has already been done in regards to health education. There was an organisation called Health Education England, which merged in with NHS England. So some of that work has already been done to try and bring together some of that structures at a national level. But there is still kind of movements that have been changed on that. But I think ultimately the principles of delivering plans and what needs to happen for local delivery still remain, regardless of kind of how the structures align to it. It's just managing to ensure that the corporate memory and the people involved are still plugged into the right bits. On the question around, because I think the question linked to mental health, but also linked to sickness absence questions as well. I mean, that is an area that kind of we are kind of highlighting in a lot of the integrated planning work. Certainly we see a variation in sickness absence across different providers, particularly coming out of the pandemic. And part of the commitment that's in the plan, the strategy plan that James highlighted, is to bring sickness absence levels back to kind of pre-pandemic levels. And that also does link into the case study, which I kind of touched on very briefly around temporary staffing, because a lot of the use of temporary staffing is driven by a high sickness absence because the temporary staff are being used to cover those absences. So it is definitely a key focus. We provide the data that shows that variation. There is also in the NHS one of the biggest surveys in the world, which is of NHS staff, that kind of shows how responsiveness to health and safety is happening for staff. That shows in different places, where there may be areas that need to be targeted, what kind of things need to be done. And there is a program that looks very much around making the NHS a more flexible employer, because part of that is about being more flexible as employers to ensure that people kind of feel safe in the work that they're in. So there are a lot of programs to do that, and a lot that's been driven locally by employers to try and bring down those sickness absence rates so that we can have more substantive staff delivering services.
I can pick up the question from Benita around future workforce requirements as well. So I think there's a couple of points here. Nationally, we do share data with those different planning bodies regionally around forecasts, population changes over time. And also we have a needs-based formula which predicts healthcare need and demand over time, driven by those population changes. And that drives how we allocate financial resources. And then really it's a case of those local planning bodies using both the data, but then also the resources to think about what's the right mix of services for their area, depending on the kind of shape of their demographics and the services that they need to deliver and the type of geography that they're operating in, recognizing that they'll need to vary that. And there might be particular kind of supply side factors around kind of where different hospitals are located, which determine the types of services they want to invest in, and what the size of those services should be. So it's quite a local answer, I think, about then determining what the right mix of workforce is into the future, which we wouldn't kind of want to define nationally. We have, in recent years, for the first time, begun to set out high-level projections for future workforce need nationally in different professional categories. And we are, the government is in the process of updating that, and we'll publish an updated version of that soon. So there is definitely focus on how to plan a workforce for the future, but it's important to kind of get the right dynamics between national and local, and kind of make sure that people are making informed decisions about locally agreed priorities, because otherwise there's a risk that it won't actually happen in practice. I think that's important.
Great, thank you. And we'll come back to you, but now I will reflect on some of the responses to Liz's question. You wanted to know what skills and tools health workers need to advocate for better financing for health. So there is a response that speaks to factoring in the investment in education and training. I think since your presentation focused quite a bit on the subspecialty of anesthesia, investment in education and training that's required to sustain a supply of the workforce, especially the professionally qualified ones who take many years to train. And so they're thinking that there is a challenge of employing qualified people all over the world, and it will be interesting to hear views from the different panelists. But specifically to the question, people think that health workers need to be educated and trained in healthcare financing, so that they are better able to advocate, about these issues. There's a reflection about, the learning attitude of health workers to the broader policy trends and health trends, both in the countries, in the region. And so the fact that, health is connected with many other things, economics, technology, research, policy, and to what extent do health workers and, are exposed to these additional disciplines, or at least interdisciplinary collaboration that can bring together the evidence needed to drive advocacy. Then there is also a reflection on, mortality being a lot due to system failures, and so the need to train informal skills and quality improvements. I think there's a call out to the Toyota IHI methodologies, and in leadership skills. So not just for people in leadership positions, but also for the frontline health workers, who are the people who see problems daily and are able to address them. And understanding cost-effective approaches and what are good buys. And I guess from the perspective of even a local planner at the district level, or given, the increasing move towards facility autonomy in countries, this could be a useful skill for frontline workers. So, and I'll give the floor to you, Liz, but I think Alex as well, if you have any reflections on some of these feedback, I'll be happy to hear them. Liz, the floor is yours.
Thank you. I think what we are learning is, well, I think we know this, health workers sometimes speak a lot of jargon. And so when we are advocating, it's almost like we're speaking to each other as opposed to speaking to the people who actually make decisions where finance is concerned. So one of the things that we're doing with PATA, but also starting to do with the residency programs, is to make sure that there's within the training embedded some leadership modules, there's embedded some storytelling modules, there's embedded, almost like a couple of modules that teach about basic health financing, basic learnings around the health systems. And we think that in the very least gives them the foundation for them to start the conversations around that. Obviously, if they want to venture into learning about health systems and health financing in more detail, they can. But I think just integrating and being very flexible to the curricula to make sure that they meet the needs of the current times is extremely important. In terms of training of healthcare workers, and then they do not have jobs, I believe every person on this panel lives in a country where that's an issue. There are advocacy efforts that are going on with the ministries just to let them know that, people are being trained and they need to be deployed, and showing them the need. But one of the studies that was done in Uganda actually shows, at least for the anesthesiologists, people don't want to go to the rural centers and remain alone. So when a job is advertised that it's just for one anesthesiologist in this great big hospital, 500 kilometers up north, it's unlikely that someone will apply for the job. The study basically showed that people would rather go with a colleague so that, they hold each other up while they're there, as opposed to being alone. And this feedback has been given back to the ministry. I believe that that's something they're working on. And we hope that when the positions open up, there's going to be some thoughtful allocation of positions to make sure that at any one point, the specialists are not on their own and they're not the ones running the show. Because what happens is when you start to run the show on your own, then you can't do the clinical work. And then, your presence there kind of defeats the purpose. So yeah, off the top of my head, those are the things that I think about. Over to you, Alex.
Thank you. And I think I agree with a lot of what Liz has said. So maybe just two things I'd add. One is I think that, what we've seen is there's quite a lot of training which is not very impactful, and a lot of putting people in conference rooms, often at quite a lot of cost, and then sort of boring them to death with PowerPoint presentations. And so I think one of the key questions is, how do we shift from that model to a model where it's really about using adult learning principles to change the way health workers are trained, not pre-service, but particularly in service. And that, I think someone I saw in the chat, what's the right balance between digital and in-person or something like that. And I think the answer is it depends on the context, but there clearly needs to be a balance. And we also know just using digital doesn't work either. You do need some, do people learn in different ways, and some things are more amenable to be taught in different ways. But finding new methodologies and new approaches to ensure that knowledge can be shared and using a whole suite of them is the most effective. So that includes classroom-based training. That includes ongoing coaching and access to a manager who actually can support you and help you and coach you. That includes access to peer-to-peer learning fora where you can find access to where you can talk to others who may be struggling with the same problem. Includes online courses that you can have access to, or if they're not, if you're in a resource-constrained environment where maybe you can't do a fully online course, a WhatsApp service which you can message with a chatbot. I mean, there are many, many different ways that learning can be imparted, and I think there are some countries like Rwanda, where I am right now, where they've fully embraced that opportunity, and it's amazing to see how people are learning and the access to resources they have. And there are others where I think it's still much, much more based on the old-fashioned way of teaching, and really think there's an opportunity there to do more, even with the existing even with the resource constraints that every country faces. The other thing I'd call out, which I don't think it's come up, so I think it's worth calling out, and it goes beyond the specific question, but I think it's pertinent here too, is gender. We know the majority, certainly in Africa, the majority of health workers are female. The majority of managers are male. And there are often gender-specific dynamics in the countries we're working with, which limit access of women to the same opportunities to learn or to impart that learning than men. And that can be something that could be about digital literacy. It can be about who actually gets prioritized for learning opportunities. It can be access sometimes to the tools, the resources, even access to a mobile phone. And so I think one thing we've really tried to work on as we think about the health workforce and more broadly service provision with countries is, how do gender dynamics actually impact the way that health workers are able to or not able to access learning and information? Because if we're not thinking about that very gender specific dimension, we're probably missing certain hidden barriers that are preventing health workers from getting access to the learning that they need.
Okay, great. So we have a lot of questions lined up from the audience for you, our panelists. So we'll move quickly to those, and I'll try to go around each of the panelists and in between throughout some of the questions that are not specific to any one person. And so to you, Alex, our first speaker. So a question: immunization benefits all of society. Is there an appetite in any setting that you know of for cross-government, cross-sector, including industry participation in enabling vaccine uptake and access?
So the very short answer is yes. But I probably should say more than that. So firstly, to start off, Gavi, I mentioned our core partners at the beginning. We're a public-private partnership. We work closely across sectors, including with the vaccine industry, because a core part of our model is actually being able to access vaccines much more cheaply by aggregating demand than is possible than would be possible if we were paying the same prices as kind of higher income countries. We're quite careful about conflicts of interest as we do that, and so we need to, we put very careful safeguards in place when we work across sectors, and particularly with the vaccine industry. But I think the challenges we see affect every stakeholder in the immunization and frankly in the public health space. When you see misinformation or hesitancy, it doesn't matter whether you are a government who's trying to reach reach communities, you're a development partner, you're a vaccine manufacturer, you're a representative of that community. We all suffer as a result, and so the need is shared, but also the solutions have to be shared. Ultimately, in the case of misinformation, it's probably the community leaders, community health workers who are best placed to actually address that, because they are the trusted voices typically in those communities. But that doesn't mean others can't lean in by providing the right information, by providing financing for sharing that information, etc. That's an immunization specific example, but there are others like on the health workforce problem more broadly, where the issue goes beyond immunization. So I think we're set up very much in the spirit of trying to bridge that cross-sectoral divide. I think the real question is, how do you do it at scale? Because I think what we're seeing in many cases is lots and lots of relatively small projects that are doing good work, but are quite transaction heavy to manage. And when you're trying to immunize every child in a country, or in Gavi's case, trying to immunize 70+ million children every year, there's only so far you're going to get with small projects, especially when the management constraints. So one of the big questions I think we always ask is this something which has the potential to be done at scale? Ideally, at least nationwide in one country, but ideally across multiple countries. And that could be harder because I think our experience is establishing really effective, scalable, cross-sectoral and cross-sector interventions requires a lot of work and a lot of investment, because people often, even with the same intent, come at it with a different language, different cultural reference points, different ways of working, and building that collaboration is hard work. It's often worth the work, but you can only do it so many times. And so I think one of the key questions is, where are those collaborations most impactful and most valuable, so that we prioritize and we really focus on those, recognizing there's many other things we could do together across sectors, but there's only so many hours in the day to do so.
All right, tech fail. Thank you again, Alex, for this. So my next question, I'll be going to James and Paul. We've addressed the first. Does the NHS have a specific type of tool to forecast the future needs of the workforce? Is it based on modeling, benchmark or ratios, or some other method?
So this is the question I spoke to earlier around kind of the way in which we use needs-based methodology to distribute financial resources, and then the long-term workforce planning that we do nationally in terms of our projections. So yeah, that's, as I said, it's kind of the emphasis is on locally to make decisions about how that information is used to drive local plans for services.
Great. Thanks. And we have some questions that have come up that are open to the panel, and please ask anyone who wants to jump in. So one question, in terms of supporting with training and developmental sessions, how can African countries tap into the expertise of their citizens abroad who are experts in their industry to address some of the issues addressed? Are there things in areas of designing and developing suitable training, developmental interventions, coaching, and mentoring? Please open to anyone to jump in. And although it talks about African countries, I would say actually it's a question that's relevant to any country from a low or middle income country. Liz, the floor is yours.
Yeah, thank you. I mean, we didn't have enough time, but part of the things that we do with the education, with the PATA fellows rather, is they learn together. So every Wednesday they come together on a webinar like this, with a teacher from somewhere around the world, a pediatric anesthesiologist from anywhere around the world. So you basically have fellows from Ghana, fellows from Rwanda, fellows from Uganda, fellows from wherever, and someone from either high income country or a fellow sub-Saharan country teaching and learning. But we also most recently have online modules that are self-paced and that eventually you get a certificate, and everyone has poured into this. So for us, it's a collaboration of anyone who wants to collaborate to the betterment of pediatric anesthesia on the continent. So we've got I won't say huge because they're not many, but we've got a pool of multiple people around the world who come together and give of their time to teach and to support and to mentor and to coach the different fellows that we have even after they have finished the fellowship. So I would say the COVID-19 pandemic taught us that we can learn a lot online, probably just making sure that the in-person and the didactics and the dexterity is taken care of, but also making sure that we can leverage on expertise that we have from places where physically they cannot reach us as easily as we would want. I think is something that's important. And then tracking those metrics and the impact of those, both quantitatively and qualitatively, to make sure that, again, when you're talking to funders, when you want to have like a learning management system, you can actually show the impact of what you have had. So what do you have now? How have you used it? And then why should we invest further in this kind of education to make it universal?
Wonderful. Thank you so much, Liz, for that. Two interesting questions popping up, and I'll really be keen to hear what other people think about this. What do you think are the key reasons for the declining interest among citizens in healthcare professions? This was asked in relation to Africa, but I don't think it's happening only in Africa. And how can health systems better retain talent? I think this has been touched on not as much, and I would like to really hear, particularly from the planners here, what we can do to retain talent better, and to even incentivize, I guess, more people to train in the healthcare professions. Takers?
So I think sorry.
Go for it, James.
Thank you, Alex. So the example that I very briefly touched on when we were presenting around the multidisciplinary roles that NHS England funded in general practice, I think is an example of where some of those roles require specific qualifications, and some of them actually don't require, they might require some qualifications, but they don't require extensive medical qualifications or nursing qualifications. And so they are more accessible to a broader kind of part of the wider labour force. And I think that is exciting in terms of a good way to bring new people into the health service. But also, I think it gives an opportunity to kind of distribute different roles within general practice differently, and actually hopefully supports those clinically trained professionals, GPs and nurses, to actually be able to focus on the things that they can perhaps add the most value with, in terms of how they prioritize their time, and kind of make sure that you've got a more distributed team where people are able to focus on kind of particular areas. And I think hopefully that is kind of both a good thing in terms of making the best use of the workforce and the qualifications and the skills that people have, but also hopefully makes it a more rewarding experience and one that people want to be kind of, part of into the future and kind of manage kind of stress levels as well.
Great. Alex?
Yeah, probably thinking about the other end of the spectrum, but I think in our case, there's a few key things that we've seen be effective. One is the very basics of decent working and living conditions. I mean, many of the health workers we are working with live in remote communities. They may not have access, they may be living without access to electricity, running water, etc., even in the facility. And so some basics like we've been working with countries to solarize facilities and living quarters for health staff can make a real difference to health workers' willingness to serve those communities and their ability to do so effectively. I think a second big piece is actually ensuring they then have decent working conditions, but also the support to perform. As I said, a lot of our funding goes towards supportive supervision, and it makes a huge difference of what we hear from health workers to both their ability to do their job well, but also their morale to have someone who's regularly checking in with them, seeing how things are going, helping them do their job better, etc. Because it could be a very lonely thing otherwise, especially if you're in a rural area, to be the one person running a health facility on your own. And then I think the third is really building the career trajectory for health workers. At the moment, partly because of the fragmentation I talked about, if you're a community health worker in many countries, you're probably going to be stuck being a community health worker for life. There's no pathway or formal pathway to get into being a full, upskilled into other medical professions. But equally, if you're a vaccinator, you may not have a pathway to kind of growth either. And so how do we move from thinking about individual cadres as sort of that's what people do to actually thinking about a career pathway for health workers over their career that gives them something to build towards, as opposed to essentially this being their job for life.
For those reflections, Alex, actually linked to this idea of the retention is a question. I'm not sure if anyone wants to take this on, but it's just an interesting one. How really, given that, health workers are trained some are coming from public institutions, some are trained privately, how do you determine or develop a fair remuneration formula that in a way rewards that time and investment, right? And the workload that they're expected to face. And I mean, I'll be curious to hear if perhaps James or Paul, is that something, how does the NHS address this? And unfortunately, our Ghana representative isn't available to also respond to this.
Well, I mean, we're having quite a live debate in the UK about remuneration, particularly in regards to staff. I mean, one of the things I thought helped kind of link some of this back, particularly around retention, but also links back to the other conversation we're having around making best use of resources, is often when we talk about, for example, productivity, it can sometimes be looked at purely from a finance perspective as kind of how do you kind of drive down costs. But actually, a lot of times what we hear is actually a lot of staff in the NHS get very frustrated about where there's a lack of productivity in the health system, because it's for them, it's where, because they want to deliver healthcare, and what they can see sometimes are where there might be processes and barriers to them being able to get the most out of their time to be able to deliver healthcare. And so there's a lot of work that's been happening around trying to think about what those barriers are and try and reduce some of those frustrations with staff. So there's a national program at the moment that's looking at the statutory and mandatory training that many employers have for their staff. Most of which is very important because it's about kind of training staff in very particular areas. But for some staff can be a little bit too cumbersome, can be not necessarily relevant to their role in some cases. So trying to streamline and kind of reform that element can help to really maximise what opportunity staff have to deliver their healthcare as well. Plus, there's a whole load of stuff around tech-enabled productivity that is going to really potentially help staff to make their daily lives easier, and to maybe reduce some of the kind of bureaucratic tasks that they have to do around reporting or collecting things like the kind of technology that can help capture notes and those kind of things, which might help to make people have more time for delivering the kind of frontline care that they want to. So I think that links some of the work around retention with the kind of wider point about productivity. In terms of the training element, in terms of, I mean, particularly within the discussion that's been happening in the UK around remuneration, I mean, there is a part around understanding, what particularly in kind of nursing workforce and in kind of clinical support workforce, is understanding that we as an employer, we don't sit in isolation. There are other employers that we have to compete with, and so there's an understanding of kind of what people can get out of being a healthcare worker, but also what they may have to look at in other parts if we're not offering a good enough remuneration. And so I think that goes into, we have a process on remuneration every year that looks at the factors that are driving retention rates and kind of leaver rates in the NHS, and whether or not there are some of those factors that are affecting our ability to retain staff, and that goes into that, and then that makes a recommendation around what remuneration should be for different staff groups.
Any other takers? Okay, so we'll move to another question. Now, what are organizations here or elsewhere doing to support health worker self-employment? I mean, this was asked in relation to midwives, but I guess for other headers as well. Is there anything that your organizations or that other organizations are doing to support health worker self-employment? Set up smaller clinics or so on? Okay, so that's not, I think, something that our panelists can immediately respond to. And then a question that perhaps, I don't know, Alex, if you want to comment on this one. Someone observes that there is, in some instances, a dependence as well on external partners to support investments in the workforce, or with the recruitment, or even to keep them on. And so are there any local initiatives, or also thinking what are these entities doing to help countries do more to take this on for themselves rather than relying on the external resources, given the current context?
Thank you. And I think, so a couple of reflections. The first one is, I actually think in most countries, the majority of the health workforce is paid for by the government. There are very few countries where it's primarily externally funded, but that there is still a heavy reliance on external funding, given fiscal constraints. And the truth is, many countries, certainly in Africa, are below the Abuja Declaration target of spending 15% of their budget on health, and that means that health budgets are not where they should be, and therefore there's a limited capacity to actually fund the health workforce, which I think feeds that reliance on the externals. I think there are some efforts to change that. Some of those are country specific, where there are countries who are investing heavily in their health workforce. I think Burkina Faso is an example that comes to mind of a country that's really set out a bold aspiration for how they want to scale their community health workforce and domestically finance that. And other countries are doing the same. As I mentioned in my introductory remarks, Africa CDC has also made this area a priority and is really looking to work with countries to help them scale up their health workforce, primarily through domestic funding. And from our side, what we've tried to do with countries is say, look, we understand you have gaps today, and we are happy for you to use our funding to help fill those gaps. But what we really want is a sustainability plan. 5 years from now, how are we going to, what are you going to do to be in a different situation so you no longer need to rely on our funding for these positions? It's not always an easy conversation, but we do have examples of success. For example, in Nigeria, we funded the recruitment of about nearly 5,000 health workers, most of whom have now been transitioned onto actually state government payrolls after typically about 5 years. And so it is possible, but it's hard. I think the one other thing I would say is, I think there's a huge opportunity for efficiency, even within the constrained resources that exist. What I see often is that the resources that do exist aren't being used efficiently, either because we're using a lot of it to pay for supplements to low salaries rather than paying decent salaries to begin with. We don't have efficient we're not optimizing the deployment of health workers in terms of allocating them to communities. I've been to health facilities, even in the poorest countries in Africa, that have lots of health workers, some of whom aren't very busy, and many facilities that have only one, if they're lucky. And so there is a real sort of misallocation sometimes. And then thirdly, I think the fragmentation of kind of the more project-based approach to health workforce that we see in many countries doesn't help either. So I think the first step actually is, what is that national strategy that paints the vision for where the country wants to go to, that everyone can then align behind and have a conversation that says, okay, what can the government fund today? What do they need external support for? How is the government going to, over time, mobilize more resources to take on more of that? And for that to be a continued dialogue. And that's currently, I think, not happening in enough countries, but I hope that we can get there. With that, unfortunately, I will need to get back to the seminar here in Rwanda. I do have my colleague Rita Hayem, who's the head of country health systems, also on the panel, and she'd be happy to answer any more questions that are relevant to Gavi. Thank you for having me.
Thank you so much, Alex, for your time so far, and we are happy to welcome Rita till the end of the seminar. Okay, so the other question, there is a question that's popped up about health worker migration, touchy subject. Liz, you did mention that, within your program, you had 100% retention within the continent. It would also be interesting to think what this may not remain the case, right? What happens if some of your graduates or those you're supporting are choosing or looking for opportunities elsewhere? And also maybe to come back to Paul and James to reflect a bit from the NHS perspective, how you're looking at the issue of the health worker migration, as the UK is one of the top receiving countries for health workers from Africa. How do we, bilateral agreements, and how can they be used to ensure ethical recruitment, protect rights of workers, and so for your context, particularly those who are, foreign health workers, and strengthen systems in both sending and receiving countries. So, Liz, the floor is yours first.
Sure, and thank you. That's an extremely important question. We haven't had to face it yet with PATA, but you raise a good point. I think, so the people who apply to be part of the PATA program are normally people who really want to be at home to work at home and strengthen the systems at home, because that is home. I am not oblivious of the fact that people migrate for different reasons, including finding a better life for their families, which is a very valid reason. So I think the way the program is growing and evolving over time is something that will continue to strengthen people staying in their homes, because they go back, and there's a lot of discussion around, when you go back, what are you going to do? How is your hospital going to take you up? Are you going to stay in the same position? Are you going to lead a department? What is expected of you? And those conversations are ongoing. But also from an advocacy point of view, that is exactly where we're going. We're saying, so we're training people, we're super specializing them, we're skilling them beyond what they have been skilled before. We cannot let this talent go to waste. So what I think is the continuous engagement with the fellows, even after they finish the fellowship, they continue engaging with the PATA collaboration. I think that will be a very strong point to, I guess, mitigate migration if and when it comes, but also understand the reasons why people are starting to want to migrate. The other thing, though, is also, if you looked at the diagram that I showed, there's a bit of a ripple effect. So the hope is that if 1 trains 3 and 3 trains 6 and that kind of thing, the effects of migration eventually, if and when it happens, will not majorly affect the system. So we're looking at permanent sustainability and a ripple effect where, you just have a multiplier effect as you continue to train.
Thank you. Paul, James?
Yeah, I mean,
quick responses?
Yeah, I think, from the NHS perspective, part of what we were kind of highlighting in terms of the integrated planning work, what that's intended to do is to basically look at how we match our resources, by which we mean this kind of staff, the workforce that we have, to the activity we need and the budgets that we have, And part of that is obviously trying to maximize the workforce that we have, and looking at those factors we talked about around reducing sickness and improving retentions, so that we kind of really get the most out of those resource. There is also wider strategic work that looks at kind of longer term workforce planning in terms of the needs of the population over a longer term, and what the workforce needs will need to be for that. And that goes into a wider piece of work around domestic education and training, and how that is kind of used to understand the time it takes for that training to then be kind of in the best place as possible to be able to meet the needs in the future. And I think that work is all intended to try and get as much from the domestic workforce that we have and the staff that we have to deliver the services. And then obviously there's a wider need. If there's a wider need or a gap, part of that's being met through the kind of temporary staffing element that I talked about, but also organisations as statutory bodies will seek that workforce. And so I think but what we try and do from a national perspective is to make sure that we're maximising the resource that we can draw on within the UK, and then that's being put towards delivering the activity we want, and it's just about matching that up.
Just to add as well on that, I think, as Paul says, I mean, part of the driver around setting out the long-term workforce plan is partly around making sure that the domestic training and education pipelines are kind of supporting the workforce of the future, and trying to, so we can kind of meet the needs of the population through our staff. But I think also, the UK is a country that has also had, clinicians who, whether it's through workload or for other reasons, have decided to go and work elsewhere. And so there's a really important imperative that we make the working experience within the NHS as positive as possible. And both of those drivers were behind that kind of push to have a long-term workforce plan. So I think it's important to recognise that kind of no country is immune from that risk.
Okay. And there is an important comment and question here around the inclusivity of when decisions are made. And so there's a reflection that it's important to have all voices represented when making decisions around how funds are spent. This focuses on, for instance, having nurses as the largest, part of most of the workforce, but not always represented in decisions, policy decisions, or their perspectives incorporated. But I think, again, this will apply more broadly to the frontline health workers as well. And so I would like to pose to each one of you, to Liz, to James and Paul within the NHS, and to Rita, in terms of how you, as you work with countries to program Gavi funding, to what extent, health worker voices being facilitated in the decisions and the conversations for how funds are spent.
Sure. So at Smile Train, I will speak to Smile Train because I think that's what I can speak to with confidence. At Smile Train, what we do is we partner with health centers and hospitals. We partner directly with the hospitals, and then they deliver the service. So what we do is when we, are trying to strategically plan, we have advisors from the different places who bring local context to the table. So we're not saying we want X to be done and pushing it down the pipeline without having them on board. So we basically look at them and say, this is what we want to bring to the table. What do you have? How can we help? And what do you need for this to be successful in this context? And what we've found is, what happens in West Africa might be slightly different from what happens in East Africa, might be slightly different from what happens in Southern Africa, for example. So we do have context-specific advisors from those regions who tell us what may or may not work, or how to change things and put things, make things a little different so that it's easy to implement that. And we found that model where we do involve the people who are actually delivering the service in the decision-making process around funding and around decisions has been extremely helpful with acceptance, in the partnership, but also in providing the impact that we've managed to have over the past 27 years.
Great. Paul, James?
Yeah, I think it's an important question, certainly in terms of how staff are informing decision making. I mean, we have in the NHS Constitution, which sets out a series of rights and pledges that are made centrally in terms of the rights for staff, and those are important kind of things that have to be considered in the work that we do nationally, but also what employers do locally. I mentioned there's one of the largest surveys in the world is the NHS staff survey, which provides a lot of rich data to support an understanding of how staff feel and how that's changing. And then there are some very strong staff advocates within the NHS. Certainly within the NHS England, we have a kind of a nursing directorate and medical directorate that has a strong voice in terms of decision making nationally. But within the system, there are kind of strong representatives of staff who have a role in policy making in terms of influencing policy making, and then the kind of broader democratic process kind of brings that together in terms of whether or not those staff feel that they are happy with the kind of the way in which policy is moving. So I think there is a strong voice for staff in policy making, and there's lots of different issues where there is responding to that, and as I say, there's a lot of data as well that's quite well published and available that helps drive a lot of that.
I think as well, just to add that in the UK context, and I'm sure in other countries as well, there's quite a lot of different so we call them royal colleges here, and kind of professional associations for different professionals within the medical and nursing workforce, and they play actually quite a strong role, not only in advocating for their professions, but also in terms of developing best practice guidelines and clinical guidelines that are then actually used in practice. So it's not always the case that kind of say a guideline would be imposed kind of top down from government, but actually a lot of stuff is developed with the professional workforce that are members of those specific associations. And I think that's an important, that's been a historical feature, I suppose, in terms of how those organizations have been, because many of them have been around for longer than the NHS. So I think they can play a really important voice in kind of speaking on behalf of the clinical profession.
Great, thanks. Collective voice, important. But of course, always a tension between the voice of the collective and some of the individuals who may not necessarily always fall in with the typical. Rita, from Gavi's perspective, how do you facilitate this as countries are programming your funds?
From Gavi's perspective, countries are in the lead of submitting their applications, but generally, and when they are doing this, the application is based on stakeholders' consultations and based on the needs assessment. So the application is reflecting the needs that has been triggered and that have been made clear. In addition, as Alex has said, as we're moving into Gavi 6.0, we're moving from a short-term investment to a long-term investment that is aligned with the National Health Workforce Strategy. So this is as well signaling, and this is as well a way of ensuring that whatever the discussion taking place at a government level, at a country level, is what Gavi is respecting in order to really invest within the HRH perspective. Thank you.
Well, thank you to all our panelists. We are almost at the end of the Q&A session. That passed faster than I thought it would. So I'm just going to allow each of our panelists a quick, one final thought that you want to leave the participants with in this as part of the seminar. And I'll just go in the order in which I'm seeing you all. So Liz, go.
Sure. I would say to my fellow health workers, learn the language of the people that you're speaking to. Sometimes if you're not speaking to your fellow health worker, if you speak exactly that way to the people who you need to advocate to, they will not understand you. Learn how to tell your story, learn how to tell your story well, and invest in skilling yourself in that way. And good luck with the advocacy.
Thank you. Paul?
Yeah, I mean, building on that, I think part of that is in terms of who you're speaking to. As I say, we come at it very much from a finance perspective to begin with, but actually part of what we kind of need to do is to be able to speak to the workforce audience, and for the workforce audience as well to speak to finance. And then in terms of the upskilling side of things, we've talked a lot about the kind of tools and resources that we have around data and those kind of things. A lot of those things are actually publicly available. So I think we're a universal healthcare system in terms of its funding, but actually provision is mostly publicly provided as well. So actually there's a lot of data that we put out there that I think is quite useful for people to see from a global context to really understand some of the things we're seeing in terms of what's driving different elements and factors in the UK. And so that's part of upskilling, I think, is to look at some of that data and really get into it and understand trends and what's happening.
James?
I won't add any more to what Paul has already said. That was very helpful. It was great to join in today. So thank you for having me.
Great. And Rita?
Actually, thank you for today. It was really great. It's interesting to see the different perspective, and it's interesting more to see that collectively we really need to work together in really making sure that investments are maximized, are efficient, and are sustainable for the health workforce. Thank you.
Great. Thank you again. So we are now at time, and we have reached the end of our seminar for today. I would like to thank again all our speakers. Unfortunately, Dr. Mensah-Acheampong could not make it back, but for all those who were able to stay, and for Rita who joined for the Q&A, thank you so much for your presentations and your feedback, and to the participants for the debates. Really, I think it's been a very wonderful discussion. Also thanking WHO and the partner countries who are sponsoring the program, and the continued relationship with the NHS England. So last few announcements. When you leave the online seminar today, there will be a brief survey in Zoom. Please give your thoughts and feedback. It will be appreciated by the organizers as they continue to improve the format of their seminars to suit the needs of the participants. So thank you everyone for your attendance and participation. As mentioned earlier at the beginning, the recording of the session will be shared with all participants afterwards, and the organizers will also be advertising the next seminar in the series shortly on the website of the NHS. Thank you all, and goodbye.